Hello, this is Dr. Jeffrey Borer from the State University of New York Downstate Medical Center. Welcome to this educational activity on reducing the burden of hospitalization in chronic heart failure.
The following audio excerpts are based on a recent presentation by Dr. Jeffrey Borer. These excerpts are part of a certified educational activity titled Reducing the Burden of Hospitalization in Chronic Heart Failure. To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/R428. A printable transcript, slides, practice aids, and other features are also available.
Let's begin by looking at why improvement in heart failure management is needed. Direct and indirect cost estimates for heart failure in the United States go up to $56 billion annually. The average heart failure hospitalization costs between $7,000 and $13,000. Rehospitalization rate is 50% within 6 months. The Affordable Care Act has made heart failure readmission a major focus for improvement. This pie chart shows the relative contribution of the various components of the expenditure, excluding secondary heart failure admissions and nursing home care. It demonstrates that hospital admissions account for at least 69% of total expenditures. The second largest component of cost is drug treatment at 18%. The treatment of heart failure has become considerably more effective during the past 30 years, but there are still important needs for reduction in mortality and morbidity. Epidemiological studies and clinical trials have provided considerable evidence that as resting heart rate increases, cardiovascular morbidity and mortality also increase, both in the general population and in patients with cardiovascular disease. Treatment for heart failure due to left ventricular systolic dysfunction has improved dramatically in the past 3 decades. Considerable evidence indicates that modifiers of neurohormonal activity, the ACE inhibitors, the ARBs, mineralocorticoid receptor antagonists, and beta blockers, make patients both feel better and live longer. Here's a table that summarizes the 2013 American College of Cardiology Foundation, American Heart Association recommendations for pharmacological therapy for systolic heart failure. Despite current intensive multi-drug therapy, however, 5-year survival in people with systolic heart failure remains only 50%, and hospitalization rates are similarly higher than we would have hoped. It's apparent, therefore, that newer treatment options are needed for persons with systolic heart failure. The Beautiful study assessed the morbidity and mortality benefits of the heart rate lowering drug ivabradine. The placebo arm of the Beautiful trial was a large cohort of patients with stable coronary artery disease and left ventricular dysfunction. The authors conducted a sub-analysis of this placebo group to test the hypothesis that increasing resting heart rate at baseline is a marker for subsequent cardiovascular death and hospitalization for heart failure. After adjustment for baseline characteristics, patients with heart rates of 70 beats per minute or greater had a higher risk for cardiovascular death than those with lower heart rates. That was a highly significant result. After adjustment for baseline characteristics, patients with heart rates of 70 beats per minute or greater had increased risk for admission to hospital for heart failure. In patients with coronary artery disease and left ventricular systolic dysfunction, elevated heart rate of 70 beats per minute or greater identifies those at increased risk of cardiovascular outcomes with a differential effect on outcomes associated with heart failure and outcomes associated with coronary events. Therefore, heart rate may be a biomarker that might predict the risk and may guide therapy. The systolic heart failure treatment with the IF inhibitor ivabradine trial, known as SHIFT, tested the hypothesis that slowing heart rate with ivabradine in patients with moderate to severe chronic systolic heart failure reduces cardiovascular death or hospitalization for worsening heart failure. Boehm and colleagues analyzed cardiovascular outcomes in the placebo group, which involved 3,264 patients, and also in the ivabradine group, which involved 3,241 patients. The patients were divided into quintiles of baseline heart rate in the placebo group for the analysis. In the placebo group, patients with the highest heart rates, that is at least 87 beats per minute, were at more than twofold higher risk for either cardiovascular death or first hospitalization for worsening heart failure than were patients with the lowest heart rates of 70 to 72 beats per minute. That, again, was a highly statistically significant difference. Their analysis confirmed that increasing heart rate is a risk factor in heart failure. Therefore, heart rate is an important target for treatment of patients with systolic heart failure. Hyperpolarization-activated cyclic nucleotide-gated channels in the sinoatrial nodal cells allow the generation of the IF, or funny current, or F current, a small current that importantly modulates the slope of spontaneous diastolic depolarization, itself mediated via other channels in the SA node. Ivabradine blocks the SA nodal HCN channels, blocking the F current in dose-dependent fashion, and thus reduces the rate of diastolic depolarization. This in turn results in heart rate reduction. The randomized, double-blind, placebo-controlled SHIFT study in 6,505 patients was designed to test the hypothesis that heart rate slowing with the F current inhibitor ivabradine includes cardiovascular outcomes in patients with moderate to severe chronic systolic heart failure, hospitalization for worsening heart failure within 12 months prior to randomization, left ventricular ejection fraction no greater than 35%, and in sinus rhythm with a heart rate no less than 70 beats per minute. Patients had to be receiving guidelines-based background heart failure therapy, including maximally tolerated doses of beta blocker, unless beta blocker was totally contraindicated. The effects of treatment on cardiovascular death or first hospitalization for worsening heart failure, which was the primary composite endpoint of SHIFT, are shown here. Cardiovascular death or admissions for worsening heart failure were reduced by 18% in patients who received ivabradine rather than placebo. This was a highly statistically significant result. On the basis of this risk reduction, 26 patients would need treatment for 1 year to prevent 1 cardiovascular death or 1 hospital admission for heart failure. While cardiovascular deaths were not significantly reduced in the ivabradine group, deaths due to heart failure fell by 26%, a significant reduction. At 28 days, heart rate in the patients on ivabradine fell by a mean of approximately 15 beats per minute compared with pretreatment. When corrected for change in the placebo group, the net reduction with ivabradine was 10.9 beats per minute. At 1 year, the reduction in heart rate was 9.1 beats per minute corrected for placebo, and at study end, the difference averaged 8.1 beats per minute. Symptomatic and asymptomatic bradycardia was more frequent in the ivabradine group than in patients taking placebo. Bradycardia led to permanent withdrawal from the study in 48 patients, that's 1%, on ivabradine, and 10 patients, far less than 1% of those on placebo. Known visual symptoms of ivabradine, called phosphenes, led to discontinuation of treatment in only 7 patients. The SHIFT echocardiographic substudy evaluated the effects of ivabradine on left ventricular size and performance in heart failure. Treatment with ivabradine reduced left ventricular end systolic volume index, the primary substudy endpoint, compared to placebo by almost 8 milliliters per meter square. Again, a highly statistically significant result. The reduction in left ventricular end systolic volume index was independent of beta blocker use, heart failure etiology, and baseline left ventricular ejection fraction. The mean values of the secondary efficacy criterion were similar at baseline in the ivabradine and placebo groups. but significant treatment effects were found at 8 months for ivabradine greater than placebo on left ventricular end diastolic volume index and also on left ventricular ejection fraction. Left ventricular ejection fraction was increased by 2.4% on average in the ivabradine group, but was unchanged in the placebo group. Ivabradine reverses cardiac remodeling in patients with heart failure and left ventricular systolic dysfunction. Heart rate reduction with ivabradine in patients with chronic systolic heart failure in sinus rhythm with heart rate at least 70 beats per minute and already receiving guideline-suggested therapies including beta blockade substantially decreases the risk of clinical deterioration as reflected by reduction in the total hospitalizations for worsening heart failure, reduction in the incidence of recurrent heart failure hospitalizations, increase in time to first and subsequent hospitalizations, and also significantly improves health-related quality of life, which is unchanged by placebo. This benefit reduces the total burden of heart failure for the patient and can be expected to substantially reduce healthcare costs. Ivabradine is contraindicated in patients with acute decompensated heart failure. It hasn't been studied in those patients. Patients with blood pressure less than 90/50 millimeters of mercury, an arbitrary threshold. Patients with sick sinus syndrome, sinoatrial block, or third-degree AV block, unless a functioning demand pacemaker is present because of the possibility that ivabradine might worsen the conduction defects in patients with those abnormalities. In addition, the drug is contraindicated in patients whose resting heart rate is less than 60 beats per minute prior to treatment because that's the goal of treatment, to get down to less than 60. If you're already there, you don't need a drug. Also contraindicated in patients with severe hepatic impairment because the drug is metabolized in the liver. It's contraindicated in patients who are pacemaker dependent, that is, patients whose heart rate is maintained exclusively by a pacemaker because the drug won't affect the pacemaker. And it's also contraindicated in patients who are concomitantly using strong cytochrome P453A4 inhibitors because those are the enzymes involved in the metabolism of the drug. There are several other new therapies for patients with heart failure, either approved recently or under study, that don't modulate heart rate. One is the combination of sacubitril and valsartan. That's a combination of an angiotensin receptor blocker and a neutral endopeptidase inhibitor that produced a reduction in heart failure hospitalizations and mortality in the phase 3 randomized controlled trial evaluating efficacy and safety of this combination. The evaluation was performed in 8,436 patients with New York Heart Association functional class 2 to 4 symptoms, ejection fraction less than 35%, and abnormal BNP values, and showed benefit on hospitalization and mortality. The trial was called Paradigm HF, and it was stopped prematurely by the Data and Safety Monitoring Committee due to substantial early evidence that patients receiving the combination lived longer without being hospitalized for heart failure than those who received standard care with the ACE inhibitor enalapril. Other drugs that are now in development don't affect heart rate. One is patiromer, a non-absorbable polymer that binds potassium in exchange for calcium. ZS9 is a novel, first-in-class inorganic crystalline compound designed specifically to trap potassium ions. New potassium binding agents are highly effective in reducing potassium and should help increase the safety of renin-angiotensin-aldosterone system inhibitors, particularly in high-risk patients. The impact of new and emerging therapies in heart failure management can be summarized as follows. Adding ivabradine to the regimen of patients whose heart rate is greater than or equal to 70 beats per minute despite maximally tolerated beta blocker doses provides important benefits. Sacubitril valsartan combination is indicated to replace an ACE inhibitor or ARB to reduce the risk of cardiovascular death and hospitalization in symptomatic heart failure patients with reduced ejection fraction so-called HFrEF patients, that is heart failure with reduced ejection fraction. In the next presentation, I'll introduce you to two patients who have been diagnosed with chronic heart failure, and I'll discuss the practical approaches for reducing hospitalization through heart rate reduction in systolic heart failure. Lucy is a 68-year-old woman with stage 3 New York Heart Association functional class 2 heart failure who presents for routine follow-up. She has a history of smoking, her blood pressure is 130/86, and her left ventricular ejection fraction is 30%. Her medications include enalapril 20 milligrams daily, which is the target dose in the guidelines, bumetanide 1 milligram a day, and a beta blocker, metoprolol succinate. But Lucy's maximally tolerated dose of metoprolol succinate is 100 milligrams daily rather than the target of 200 milligrams daily because she developed dizziness and fatigue when the dose was increased. She's also taking spironolactone 25 milligrams daily, again a target dose. Lucy's resting heart rate on this regimen is 85 beats per minute, and she is in sinus rhythm. Her creatinine clearance is 30 milliliters per minute. Even though that's not normal, there is no dose adjustment needed when considering ivabradine therapy. What would you recommend for this patient? Would ivabradine 5 milligrams BID be appropriate? If you initiate ivabradine, what side effects would you counsel your patients about? Given the fact that her heart rate is increased above 70 beats per minute on maximally tolerated doses of beta blockers, ivabradine 5 milligrams twice a day as a starting dose would be quite reasonable. If ivabradine is initiated, what side effects would you counsel your patients about? I would ask the patient to tell me if she noted an abnormal heart rate, that is, if she developed palpitations, if she could feel her heartbeat, because atrial fibrillation, which often is asymptomatic, is a concern in patients with heart failure, and particularly in patients with heart failure who are receiving ivabradine. If the patient developed atrial fibrillation, the drug would need to be stopped until the atrial fibrillation went away because it doesn't have any effect on heart rate in people with atrial fibrillation, and because we really don't know what heart rate would be an appropriate target in people with atrial fibrillation. In addition, I would counsel the patient about the possibility that she might feel lightheaded and should tell me about it if it happens, because the drug can lower heart rate and might lower heart rate to a level that would cause her to be symptomatic. Finally, I would counsel her to tell me if she saw flashing lights in front of her eyes. Those are the phosphenes that we talked about earlier. And if she developed them, we'd have to make sure we monitored to be certain that they weren't so bothersome that they were impacting on her ability to carry out her activities of daily living. Here's another patient. Jim is a 59-year-old man who has a family history of hypertension and cardiovascular disease. His history is significant for 4 previous hospital admissions for worsening heart failure over 2 years. He has type 2 diabetes mellitus controlled with metformin, and his hemoglobin A1C is 6.2, a reasonable value. Jim's resting heart rate is 78 beats per minute, and he is in sinus rhythm. His left ventricular ejection fraction is 37%. His blood pressure is 110/78. His electrocardiogram shows a QRS duration of 150 milliseconds with left bundle branch block. His creatinine clearance is 25 milliliters per minute. Subnormal, but acceptable with certain types of drugs. Jim currently is taking carvedilol 50 milligrams twice a day, which is an acceptable dose. His daily dose of ACE inhibitor is 40 milligrams of lisinopril, also a very reasonable target dose. He's taking spironolactone 25 milligrams a day, the usual target, and he's on a reasonable dose of diuretics given his symptoms. Jim has a history of discontinuation or non-adherence to medications for heart failure. How would you alter Jim's therapy? Should treatment be altered to lower heart rate to less than 70 beats per minute? Should you reevaluate Jim's left ventricular ejection fraction before you consider heart rate lowering? Should you consider initiating cardiac resynchronization therapy? Well, the fact is that Jim's ejection fraction is higher than the threshold for use of ivabradine. Therefore, increasing his drug or adding ivabradine to reduce heart rate in Jim wouldn't be within the labeling guidelines for this drug. On the other hand, the patient has he has dysynchrony. He has a QR restoration of 150 milliseconds and left bundle branch block pattern, which at this ejection fraction is a reasonable basis for undertaking cardiac resynchronization therapy. CRT was initiated in Jim, and his left ventricular ejection fraction rose to 44%. His heart rate remained at 72 beats per minute. His symptoms decreased following CRT. So in fact, the scenario in which CRT was initiated was quite reasonable, and ivabradine would have been inappropriate. What if his heart rate was 78 beats per minute in sinus rhythm while on standard of care therapy, including maximal beta blocker dosage, and his ejection fraction was 34%? Should you reevaluate the ejection fraction? Should you treat to lower the heart rate to less than 70? In fact, in this situation, with his ejection fraction not reaching the threshold beyond which ivabradine would not be appropriate, and given the fact that he is on a reasonable maximal dose of beta blockers, it would be very reasonable to attempt to lower his heart rate further with ivabradine, beginning at 5 milligrams twice a day and increasing to get his heart rate down below 60. So that would be a very reasonable thing to do, even without rechecking his left ventricular ejection fraction, though certainly if you were concerned that the ejection fraction measurement might have been inaccurate, that would be a very reasonable strategy as well before beginning any other drug.
Thank you for listening to this activity. To view the rest of the CME activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/R428. This CME activity is jointly provided by Medical Learning Institute Incorporated and PVI, Peerview Institute for Medical Education. This activity is supported by an educational donation provided by Amgen.